Hi, everybody. Mohammed Nami here from the Department of Neuroscience and Shiraz University of Medical Sciences, and I'm kind of very privileged for the opportunity of talking to you in this first international digital event of integrative diabetology, which has been held and moderated under the patronage of the European Medical Association. Here I'll have 10 to 15 something minutes to be highlighting some features about the intricate relationship between diabetes and parasomnias and other sleep-related issues. So when we refer to the term parasomnia, we mean abnormal sleep behavioral problems. And the studies have so far indicated that there is a solid link between poor glycemic control in patients with diabetes mellitus and a range of sleep disorders, including parasomnias or behavioral sleep issues, as well as some other prevalent types of sleep problems, including sleep disordered breathing and periodic leg movement disorder. So we'll be more focusing in the first part of the talk on the term parasomnia, which is an umbrella term that we'll be discussing about it as we walk through the communication. As for diabetes and the case of insulin resistance, we can all appreciate the fact that metabolic disorders, including diabetes mellitus, are amongst the most prevalent clinical issues, specifically in today's competitive life across the world, to an extent that only in the United States, we have epidemiological reports indicating almost 30 million people are afflicted with diabetes mellitus, and the condition is considered as the number 7 leading cause of death in the same population. It's a chronic disease, and we know that's pretty much linked to the insulin resistance. And when we have poor glycemic control, specifically hyperglycemia in long run, then we could be expecting clinical consequences and adverse impacts on heart, maybe an increased risk of ischemic heart disease in particular, and also the kidney function will be hampered. Also, we'll be having some issues with eyesight and neurological disorders. Specifically discussing about the relationship between diabetes mellitus and sleep, evidence has supported the fact that many of the diabetes patients, they are reporting inadequate sleep quality. And they complain about a range of sleep problems, specifically insomnia and other sleep predicaments that we are highlighting right in this communication. So when that's the case, and these people with poor glycemic control are referred by the endocrinologist to the sleep clinic, or they come because of their subjective complaints about the poor sleep, unrefreshing sleep, then after we do the thorough clinical examinations, history taking, and so on, then a fraction of these cases will be scheduled to undergo a test called polysomnography. So they are admitted to a hospital in our hospital-based sleep laboratory, and we are attaching a set of sensors to different organ systems. We're looking into different physiological signals and parameters, including electroencephalography, or sometimes we even do brain mapping. And also we look into the eye movement for sleep staging. We also check for the chin electromyography, the limb electromyography. We also look into the snore recording and heart electrocardiography to make sure there is no ectopic beats or a range of dysrhythmias or arrhythmias. Also, we're attaching sensors to check the chest and abdominal wall movement to make sure about the effort, respiratory effort. We also look into the flow and the pressure of the flow of the air exchange. To ensure that the breathing is there and everything is as expected. Also, we'll look at the sleep position, and the patient would be under the camera surveillance to make sure that there is no abnormal movement is there. And sometimes when they show abnormal movements, concurrently they are checked for their blood sugar, and it turns out that they have hypoglycemic attacks maybe like 3 to 4 hours after midnight. And by that, they show this kind of abnormal sleep behaviors that we collectively refer to them as parasomnias. And according to the International Classification of Sleep Disorders, we have a wide range of parasomnia symptoms. Some of them are associated with disorders of arousal in non-REM sleep, including confusional arousal, sleep talking, sleepwalking, and sleep terror. Other types are parasomnias associated with REM sleep, such as REM behavioral disorder. Patients are acting out their dreams and they are restless during their REM sleep, and they have isolated sleep paralysis. They might be having and showing nightmare disorder, might be screaming or shouting while asleep, and some of them are reporting some other behavioral symptoms, including tooth grinding or nocturnal groaning. Also, they have dissociative disorders, enuresis or bedwetting. Some other cases report the exploding head syndrome. They wake up with the worst ever reportable headache. And also, some other subjects may come up with sleep-related eating disorders, sleep-related hallucinatory experiences, vivid dreams, and that might be in some ways related to the effect of drug abuse or medical problems, underlying medical problems, or remain unspecified. So to make sure about that, we do the thorough polysomnography assessments. As you can see here in this short video, we have two cases with diabetes mellitus that they have come to our doors and we've done polysomnography. In one case, it turns out that a subject has an abrupt decline in the glucose level in the middle of the night, and he showed frank, robust symptoms compatible with epileptic seizure, with focal and paroxysmal epileptic discharges in the EEG during sleeping hours. So that was a typical case of parasomnia in sleep, which was associated with epileptic symptoms. Some other cases may not be epileptic. They are just showing parasomnia as abnormal behaviors because of a decreased level of glucose, serum glucose, and the hypoglycemic attacks. With regards to the metabolic syndrome, we have seen in many cases that we have like a cluster of symptoms coming together in most instances, including central obesity, hypertriglyceridemia, and the low level of HDL. Also, subjects would have hyperglycemia and hypertension. And collectively, when we have the symptoms together, then we might be referring to an increased risk of cardiovascular disorders and also the incidence of diabetes mellitus or poor glycemic control. Many cases with diabetes, while they have poor glycemic control, then or poor HbA1c level, indicating poor control, that they might be showing or reporting or subjectively reporting some sleep issues. So when we look in depth into their sleep features and structures, and it turns out that the metabolism is hampered. The glucose metabolism during the sleep hours is not as it should be. And that's because they have a kind of sleep problem. They have this on and on ongoing physiological challenge during their sleep fasting and sleeping hours, and by that they would have the gluconeogenesis in their sleep. The leptin secretion is off the chart, and then we have an increase in growth hormone level. And so these regulatory and counter-regulatory mechanisms for the metabolism of glucose are kind of dysregulated, and by that, in the wake feeding, the subject would show an increased level of sympathetic tone, and also glucocorticoids will be higher in serum, and also the insulin secretion will be increased. And when this goes on, and the patient is also a subjected case of a suspected case for sleep deprivation or prolonged wakefulness or high-fat diet and untoward lifestyle habits, then by time the insulin resistance would be the case, the insulin secretion is decreased, and the diabetes and poor glycemic control would be there. So by time, we see that this insulin resistance would lead to an increased level of lipolysis by lipoprotein lipase level, and abundance of free fatty acids, and by time we would have an increased insulin resistance and impaired insulin mediated glucose uptake, And consequently, we would have hyperglycemia, which results in type 2 diabetes mellitus, a poor diabetes control, poor glycemic control in long run. And that's not the full extent of the story. We also have some subjects with diabetes mellitus that they have obesity at the same time, and they have a range of sleep-related breathing disorders, including sleep apnea. It has been shown that almost 50% of the cases with diabetes mellitus, they have sleep problems due to unstable blood sugar level, accompanying diabetes-related symptoms, hyper or hypoglycemia, also insomnia and fatigue and excessive daytime sleepiness or EDS in the following day. And those cases with diabetes mellitus would have a higher risk of developing accompanying sleep disorders. Two of the main prevalent sleep symptoms in patients with diabetes mellitus and poor glycemic control include sleep obstructive sleep apnea hypopnea syndrome, as we said before, and restless leg syndrome, more specifically periodic leg movement during sleep, or PLMD. For diabetes and sleep apnea, we know that evidence-based medicine showed that sleep apnea per se is not directly inducing diabetes mellitus, but it is considered as a risk factor for DM. And the condition would increase the insulin resistance, even in non-diabetic and also non-overweight subjects. It has been shown that up to 25% of the cases with DM, they also suffer from obstructive sleep apnea hypopnea syndrome. That might be in some ways related to their obesity. There might be related to the neurological dysfunctions. And further, the quarter of the patients with diabetes mellitus type 2, they suffer from another sleep-related breathing disorder that might be just snoring, which is pathological snoring, a high-pitched snoring, which is accompanied by flow limitation or hypopneas, or they might be having other issues with their sleep structure when it comes to oxygen saturation and intermittent hypoxia. In many studies, and some studies that we have done in our setting, we have documented that short-term sleep apnea treatment is known to improve blood sugar level in cases with diabetes mellitus. And according to the evidence, we have demonstrated that, and also some other researchers have demonstrated that long-term CPAP treatment would improve the blood sugar and insulin resistance. However, in some cases, although we're doing the PAP therapy in a proper way, but the glycemic control is not there, and in those cases, we believe that it might be related to other underlying features and variables, including obesity and a high BMI. And we need to dig into more details when we're confronting issues with poor glycemic control and challenging sleep problems. So it's like a teamwork between endocrinologists and sleep physicians and cognitive neurologists and also sleep neuromedicine experts. Why I say cognitive neurology? Because many of these cases with sleep apnea, they start to develop problems with their cognition during the sleep hour, during the wake hours. So that's also another important issue to tap into. A question is, how can people with diabetes, they cope with sleep issues? We got a distinct set of recommendations. Collectively, we call them sleep hygiene measures, sleep hygiene recommendations. So we advise these cases with DM and sleep disorders first to adhere to a diet plan under the care of the dietitian that they know it works best and helps their blood sugar control. Number two, we advise them to get a regular exercise and to stay active, and also get regular in terms of the sleep and wake hours. So keeping a regular sleep schedule and avoiding stimulants like caffeine or nicotine before bed, and also keeping the bedroom cool, dark, and quiet, and just follow the whole set of sleep hygiene recommendations and suggestions. So if that's the case and still we do not see the favorable result in glycemic control, and sleep disorder is there, we got to be going for further analysis. We might be having like a team approach with endocrinologists, sleep physicians, neurologists, clinical neuromedicine experts, and sleep physicians. Collectively, what we put all the data and the evidence together to find a solution which best works for these cases. So there's always a way, and we need to look into the problem in a very specific and a delicate way to make sure that sleep and diabetes are going hand in hand, and we got to be make sure uh, we got to be making sure to provide the people with clinical solutions to make this balance between their sleep quality and quantity and the clinical condition of the diabetes mellitus. And I hope that this would be only the beginning of the thoughts and teamwork, and also the connect approach that we would have for a betterment of sleep quality and quantity, and also glycemic control in patients with diabetes mellitus. There are many of them worldwide. Thank you very much for listening and for tuning in.